treatment of neglected club feet, and specifically I want to talk about the Paver scoring system, which is a new scoring system specifically designed for older children. That means for neglected or recurrent club feet, like you see on the picture there. And I'll explain to you later how I came across that score. Brief explanation, I came into contact with club feet only since I moved to Africa nearly 20 years ago. And I learned a lot from Dr. Murila while I was working at Kikuyu Orthopedic Rehabilitation Center for 2 years. And then also I worked in a pediatric orthopedic hospital in Tanzania for 5 years, where we treated a lot of club feet. And since I came back to Kenya 9 years ago, I worked with APDK. So what is a clubfoot? Just some basics to start with. Congenital talipes equinovarus, as you all know, derived from Latin. As you can see here, equinus actually means like a horse because the foot is pointing downwards. Now, this doesn't describe all the deformities of the club feet because there are 4 deformities there. Cave in Latin actually means be aware. So that's easy to remember. So you have the cavus, the adductus, the varus, and the equinus. It exists, it's relatively common, congenital deformity. They say between 1 and 2 in 1,000 live births. Some authors say it's more common in Africa than in other continents, but I'm not so sure about that. Of course, there is a congenital factor in there. 2.5 to 3 times more males affected than females, and in half of the cases, it's bilateral. Now, I'm going to start with surgeries because the aim of this presentation is actually to get you away from surgeries. So as I start with surgeries, I hope you've forgotten about them by the end of this lecture. The most common one is probably the Turco. That's also the one I performed mostly in my young and exuberant years when I didn't know about conservative treatment of severe club feet. It's a lengthening of several tendons, and you have to release the capsules, especially posterior subtalar and talonavicular. This incision is quite a long one on the picture I found, but that is up to any surgeon. So those I did quite a few, and the results were mediocre, to be honest. Some went very well, but others, they recurred very quickly. A pretty ugly operation, in my opinion, is the Cincinnati. The advantage is, of course, that you expose all the areas that are affected, and you have very easy access to all the tendons, to all the joints, to the capsule, and so on. But it's not easy sometimes to close the skin again after such a massive intervention. And you can certainly not put the foot straight away into a neutral position. You will have to keep it in an equinus position until the skin is healed before you can reduce the equinus. That's why I never liked that operation. There's also a Carroll technique, which I only came across because I researched for this lecture, where you do 2 incisions, but basically is the same form of soft tissue release where you release tendons and the capsules. On the bony interventions, one of the most common is probably the Dwyer's osteotomy, where you do a medial opening wedge of the calcaneus, mainly to correct the heel varus. But it doesn't correct much of the other involved deformities. The Lichtblau procedure, quite rare as far as I know. You have a lateral approach where you do a closing wedge of the calcaneus. It should prevent the long-term stiffness of the hindfoot, but I don't have any experience with this one, so it's just for the record that this exists. Similar case with the Dillwyn-Evans osteotomy. Here you already attack a joint, which means there is one joint that will be fused for the rest of the patient's life. And of course, it will result in some stiffness of the foot. And that's why the joints involving osteotomies are reserved for older children. Then the most aggressive part or most aggressive operation is, of course, triple arthrodesis, which should really be reserved for older children with, where there's no more growth potential, if possible. And there are different techniques again. There's the Dunn arthrodesis and the Hoke and Kite version of the triple arthrodesis. I have only done about 4 or 5 of them, and all of those kids were 14 years or older. And so you have, of course, a massive stiffness of the foot afterwards, and basically the only dorsiflexion and plantar flexion will result from the ankle joint and not from the other joints that you have fused. Talectomy is also very radical. I learned that a talectomy should only be done in cases of arthrogryposis, where it's really your last resort in getting the foot in a somewhat plantigrade position. The X-ray afterwards looks quite ugly, with the tibia sitting directly on the calcaneus. And of course, there will be some stiffness. So it's really for one of the last resort techniques. Ilizarov, or the Joshi external stabilization system, we use that a lot when I worked in Tanzania for neglected club feet. It is quite an elegant method, although you also get complications there with pin tract infections, and of course the adjustment of the Ilizarov, which is done every day. The children are not very happy with you if you do that every day to them. But during the period when the adjustment time is over, they're usually quite happy chappies. And we had about 5 to 10 patients in our ward there on every single day with an external fixator, with an Ilizarov. And the results were quite good, but I don't know how the long-term results were, because we usually didn't see those children again after a year or 2. I put this slide on purpose, very busy, to illustrate all the complications of surgeries. The aim is also to get you away from surgery. The most severe complications I saw they were fortunately not from our hospital, that was also in Tanzania, but there was a group of American surgeons who had done loads of clubfoot surgeries in an outlying hospitals and sent their complications to us. I remember 5 of them. 4 of them were very severe infections that needed multiple debridements, and a couple of them even skin grafts. And 1 ended up in amputation because the infection or the foot was actually also put in a very tight plaster. And in the end, it was gangrenous, and we had to amputate the foot. So these are severe complications of surgery. That's why we go to Mr. Ignacio Ponseti, who is probably the hero of clubfoot surgery, of clubfoot treatment. Sorry, not surgery, clubfoot treatment in Africa and the world. He was born in Spain, but then immigrated to America and developed his own system of conservative manipulation, casting, and bracing of club feet. And he changed the way club feet were manipulated and casted from Dr. Kite, who initially advocated to reduce and manipulate the clubfoot around the ankle joint with your hand or your thumb on the lateral malleolus instead of the talus. And Ponseti said surgery is the wrong approach for the treatment of clubfoot, and I can only sign up for that. A brief rush through the Ponseti technique. One main thing is manipulation. That means Ponseti doesn't mean just pushing the foot in a decent position and then casting him straight away. The manipulation is an integral part of the Ponseti techniques. That means the foot first has to be manipulated for several minutes to try and reduce the deformity before you even think about casting. And one of the most important factors is that you need two people to do it. You need an assistant to hold the foot so that you can manipulate the foot in peace. How it is done, exactly how the movement of the tarsal bones is involved and how the soft tissues shift around is well demonstrated, so I don't need to dwell on that. The Paver's correction is probably the most tricky part, which means that the supination and the adduction and the Paver's and the varus all have to be manipulated at the same time. If not, you won't get a good result. Again, the manipulation is very important. You don't just push the foot in a position and leave it there and then get the cast on. You slowly manipulate the foot, push it a bit further, push it a bit further until you get a decent position. Padding, very important. Plaster is always done from the bottom up. That means you first apply the below knee cast, let it dry, mold it nicely, and only after that you actually then go to the extension of the cast above knee. Why above knee cast? We'll come to that in a minute. Another important factor which is sometimes overlooked is the plantar support for the toes, because in baby club feet, the toes are usually curled into quite a severe plantar flexion. So you need a support under the toes to also stretch the flexor tendons and muscles. The progression of the casts is shown nicely in this slide, where initially you reduce slowly by slowly. Most important in Ponseti, you never attempt to reduce the plantar flexion or the equinus until you get to the tenotomy. And the tenotomy happens between the 4th and the 5th stage here on this slide. So until you get to the 4th stage, you leave the foot in plantar flexion. A very important factor here, which I've seen not happen in some cases in clubfoot clinics, is the external rotation of the foot. And this external rotation, you can only achieve it with an above knee cast. So a below knee cast, if you ever see below knee cast and somebody says, I'm doing Ponseti, that's not correct. He's not doing Ponseti, he's doing some own invention. So between stage 4 and 5, you do a percutaneous Achilles tenotomy, and that is when the plantar flexion can be reduced. Afterwards, you apply braces. You don't need a Dennis Brown splint that costs about 40,000 shillings or something around there. You can use the normal foot abduction braces. The S in the SFABs here stands for Michiel Steenbeck, who is a physiotherapist who was instrumental in developing the Clubfoot program in Uganda, and then came up with this simple method of doing braces, and that's why some people call them Steenbeck foot abduction splints. Bracing is done for 24 hours for 3 months and so on. I'm not going to dwell on this one, but it's important to know that the bracing is probably the most important part of the treatment, because without bracing, or if there's non-compliance with the bracing protocol, the recurrence is very high, or nearly all the feet recur, and you'll have your recurrent clubfoot. You have scoring systems, Pirani and Di Meglio. Both are used, some use Pirani, some Di Meglio in the Ponseti treatment. They both have a relatively high accuracy, but inter-observer accuracy is not so great. That means if 3 people look at the same clubfoot and classify it according to Pirani or Di Meglio, they can come up with some very different numbers. On the other hand, both scores are mainly done for the progression of your treatment. That means you classify the foot, you measure the foot between each cast change so that you can see if you are going in the right direction. So if the same person does it all the time, then it doesn't matter so much, because then the score will change according to the observation of that person. Now, these scores don't work very well for neglected club feet. In this picture, you actually see that it is hereditary. So the mom has club feet and the boy has them too. Not sure if it's a boy or a girl, by the way. So Dr. Nan, who's worked for many years in Ethiopia, came up with a new system, the Paver system. I'll explain to you what Paver stands for. He developed this score because the Di Meglio and Pirani doesn't work really well in older children. And with the calf atrophy you have, and with the lateral border that is always curved, both scores are not so applicable. Both the Pirani and Di Meglio actually measure 6 different factors, but the Paver score only measures 5. It measures the plantaris, adductus, varus, equinus of the hindfoot, and the rotation around the talar head, and that gives you the Paver. The plantaris is not the same as equinus, as you might think. Plantaris is actually the plantar flexion of the forefoot compared to the mid and hindfoot, and the equinus is the flexion in the ankle joint. We'll do it step by step. This looks confusing in the beginning, but when we'll go through them individually, you will see what it means. You measure the 5 different factors, and to get to the end score of the Paver score, you have a multiplier depending on the age of the patient, and as Dr. Nan only included children between the age of 2 and 10, the multiplier applies for the same age group. So how do we measure the Paver score? The plantaris, as I said, is not the equinus position in the ankle joint. It is just the plantar flexion of the forefoot compared to the hindfoot. And with some lines drawn, you see in this case it's not very high. So the Paver score for this foot, for the plantaris, would come to 1. The adductus is done with the patient kneeling or lying on a bed and on his tummy. And you basically draw a line between the calcaneus and the forefoot and measure that angle. In this case, you'll get a score of 2. The varus is a bit more tricky because the varus measures the varus position of the calcaneus as compared to a straight line drawn through the tibia. So you have to imagine that a little bit, but in this case it's not very severe and the score is 1. I forgot to mention actually that all these measurements are taken with the observer trying to reduce the foot to the best possible position. The equinus is pretty straightforward. How much equinus is there in the ankle joint? In this case, it's quite severe, so we come to a score of 3. The last one is a bit more tricky again. It's the rotation around the talar head. You basically draw a line along the anterior tibia and have your hands on the calcaneus and try to reduce the internal rotation of the foot. In this case, in 44 degrees, the score comes to 2. The calculation of the score, you add the 5 measurements that you have taken. And in this case, the patient was 8 years old, multiplied by 2. The diastemic area, and the higher the pressure, the more severe the clubfoot is. But the Paver score was mainly done to see how many casts will be needed and will the conservative treatment be successful or not. As the casts were only changed every 2 weeks, the treatment can last up to 5 months in very severe cases. This is a picture how they do it in Ethiopia. The flexion of the knee is a bit too much in this case because for older patients, they prefer to only do about 60-degree flexion of the knee to prevent further stiffness of the knee joint, and that seems to have worked quite well. Most patients, or all patients, got actually Achilles tendon lengthening, were a percutaneous one with the Hope techniques. That means 3 stab incisions. In this study, they did a lot of tibialis anterior tendon transfers. I'm honestly not totally convinced that it is necessary in most cases, because especially when you imagine that there is a lot of muscle atrophy in older patients with club feet, the strength of the tibialis anterior is usually not so great. And if you have a strength factor from 3 or lower, then the tendon transfer doesn't really make sense, because you need at least 4 or 5 for tendon transfer to be effective. So the ease of the correction and the number of casts are both predicted by the Paver score. So the higher the score, the more difficult it is, and you can actually predict if you will fail. So you can exclude patients with a Paver score of 18 and above, and we probably will have to do surgery on those straight away, because the conservative treatment with this modified Ponseti method will not work. This is a graph that shows you all the patients with their scoring. Some had a very low scoring, around 1 only, so not very severe club fit. The majority were around 10. The white dots actually represent all the successful casts, and you see that one score of 20, a patient with a score of 20, was corrected with conservative treatment with an Achilles tendon lengthening. And the cases that didn't work are the red dots up there, who had Paver scores of 18 and 20 and above. So the probability of success with a score under 18 was 97%. So nearly all the cases who had a low score of 18 and below were corrected successfully without major surgery. And one patient with a score of 20 was also corrected successfully without major surgery. So the Paver score, a good association between the number of casts and the achieved correction, and a useful score to predict the success rate. Now, this is a small advertisement break. I came across the Paver score on Mercy ships. Mercy ship is the biggest hospital ship in the world, and they travel to a different West African country every year, where they then stay in the harbor for 8 to 9 months, and the ship is fully equipped. There are 5 operating rooms on the ship. There are inpatient wards. There's 5 inpatient wards with 20 patients each, and a crew of 450 that all sleep on the ship. Now, they have also a very intensive Clubfoot program, and that runs during the whole period that the ship is in the harbor, and doesn't happen on the ship itself. It's usually outsourced to a clinic where the Ponseti experts work with local medical staff and teach the method, teach them the Ponseti treatment, teach them the casting, the tenotomies, and the bracing, and in some cases even the fabrication of braces that are needed after the casting. So this is an example of a very severe clubfoot that was treated, as you can see, over 4 months. The week 15 picture is actually still before the tenotomy. So this is the left foot of the patient. We'll see the right foot in a minute. So week 8 means the patient had 4 casts until then, because they change every 2 weeks. And you see how slow the progression is, but there is a good progression. Concerning the restretching, which they also did on the left foot, what they do is they usually do just a percutaneous tenotomy and then take the patient back into the operating room, and with some sedation push the foot a bit further a couple of weeks after the tenotomy. I'm not sure that that is absolutely necessary. In 2 cases when I was on the ship, I actually performed a small percutaneous posterior capsule release by just going through a stab incision towards the posterior capsule and cutting away there until I felt that there was a release and the foot went into dorsiflexion. So the restretch is a matter of technique and how you would like to do it. Those pictures were taken by Nick Beltians, who is a physiotherapist who has served on Mercy Ship now for the last 4 years, I think. And not only has he taught many people in Guinea, Senegal, and they were 1 year in Madagascar, but also set up a Clubfoot program in those countries, which is still active now. So they're doing a fantastic job. So this is one case from Ethiopia, which was their most severe case that they wanted to picture. And they show here how a very severe clubfoot was converted into a plantigrade foot. And I can assure you the only operations this patient had was a percutaneous Achilles tenotomy and an anterior tibialis tendon transfer. So in conclusion, children up to 10 years can be treated with the Ponseti method. So don't grab your knife straight away when you see a child of 2, 3, 4, 5 years, because even if the Ponseti treatment fails, the surgical procedure that you have to do in the end is usually a lot less invasive and easier than if you hadn't treated with Ponseti and with conservative treatment before. I looked up which papers are out there. I found one from Nigeria where they treated 328 club feet and had a success rate of 78%. I'm not quite sure what the age distribution was for those patients, and they certainly didn't use the Paver score because it wasn't available then. And then there's this meta-analysis that looked at 12 different studies and had over 600 club feet in them. And they said the satisfactory outcome was 89%. So it's not good outcome, but at least satisfactory outcome was 89%, which demonstrates again that surgery is not necessarily the first choice for the treatment. I have to thank Tim Nunn a lot because he allowed me to use slides from his presentation where he talked about the Paver score. And I can put that link actually in the comment section or something so that you can look it up on PubMed yourself. And I think I made it with 1 minute to spare. This is a patient actually from Mercy Ship who was treated in Guinea when I was on the ship there. As you can see, very severe club feet that resulted in a plantigrade foot. I don't have the video of him because the video actually shows that he's walking very nicely with plantigrade feet. So thank you for your attention, and I'm open for questions.
Thank you, Dr. Kinsch. There's some questions that have been typed. You're able to access them?
Let's have a look and get out of the screen share. Yep. Are we?
All right. Under the first question.
Yeah.
Kindly from Dr. McKenna, kindly differentiate the terms, these terms in terms of specific timing and severity. The terms are recurrent,
yeah,
residual,
yeah,
resistant,
yeah,
and neglected clubfoot.
Very good question. The easiest answer is on neglected, because that's a clubfoot that never has received any treatment whatsoever. The other three terms are for, let's say, attempted treatments or residual clubfoot, a clubfoot that has been treated but has not been fully corrected. If that is done, if you name it residual after the plaster treatment, then it's probably a proper residual clubfoot. If it is after bracing, as the bracing is so important, if the bracing is not done properly, then it will become recurrent clubfoot. Neglected clubfoot can be the same, can be a clubfoot that has been treated before, then the bracing wasn't done properly, so it's back. But neglected can also stand for a clubfoot that was never treated. So they all glide into each other, and I wouldn't put too much importance on it. I would just say it's a clubfoot that needs treatment.
Okay. Then the next question is, explain rocker bottom deformity.
Okay, a rocker bottom foot is when a Ponseti specialist or somebody who does Ponseti treatment tries to correct the equinus without doing tenotomy of the Achilles tendon. You can imagine if you cut the Achilles tendon, then the foot comes up nicely in the ankle joint. If you don't cut it, you are pushing the forefoot up, and the back foot is still in a plantar flexion. That means the foot will look like a U, the letter U, with the middle of the foot being in contact with the ground, but the toes and the heel not in contact with the ground. So that's a very unfortunate deformity, and the children will not be happy with that and will not be able to walk properly.
All right, then the next question is from Asif Admani. This, I think, is Dr. Asif Admani. Could you comment on your experience with dynamic supination as an outcome in clubfoot treatment?
Oh, I must pass there. I don't know what he means with dynamic supination. I haven't come across that. Sorry.
Okay, then. From Paul Okutoi. Thank you for the great presentation, Dr. Stan. The Paver score seems not to consider flexibility or lack thereof of the deformed foot. Do you think this would be an issue for the older child, especially?
Okay, I can see the questions now. I think that is a major issue, because what you do when you score according to the Paver system, the same as you do with Pirani and Di Meglio, is actually you try to reduce the foot to the best possible position that it can go without breaking it, basically. So your scoring, the scoring actually shows you the lack of flexibility that the foot has. And so if the foot is very stiff, then the score will be a lot higher. And that will again give you an indication that the foot will be difficult to correct with conservative methods and will probably need a surgery.
Okay. You can see the next one.
How many trials of Ponseti? Well, I don't know what you mean with trials of Ponseti. Ponseti is one series of trials. That means you, even in newborns, when the Ponseti is started as it should be, very early, you don't know right away how many casts you will need until you do your scoring. That means even the Di Meglio and the Pirani will give you an indication already how many casts you will need to correct the deformity. And the aim is always to correct all deformities apart from the equinus before doing the tenotomy. Now, I know that in the study that Tim Nunn has done and on Mercy Ships, when they did it in Senegal and Guinea, they had patients where they went up to 10 to 12 casts. So they cast it for the 12 casts means 6 months basically, because they change the cast every 2 weeks. And not all of them were successful, but the vast majority was actually successful. If you still see a progress every time you change the cast and your score improves after you change the cast, then you should continue. And that's why the Paver score is so interesting. If you have a Paver score of 18, which is basically borderline, you can imagine that you need probably 4 months to correct it completely. That means 8 casts or even longer. If you have a Paver score of 2, 3, 4, you might be able to achieve it in only 2 months or only 4 casts.
Okay, there is the next question. You can see it.
Okay. Neurogenic.
From Dr. Philip.
I see Emmanuel here. Philip first. Okay, sorry. Tenotomy is done. Yeah, the tenotomy is done at the very end, like with the normal Ponseti technique. It's done when all the deformities are corrected apart from the equinus. That means you basically have a foot that would be plantigrade if the patient can lift the foot to a neutral position. So it's the last step. And after the tenotomy in Ponseti, but also it's basically both of them are Ponseti treatments. So the tenotomy is always the last step. Then you apply 1 or 2 more casts after the tenotomy, and then the foot goes into a brace.
All right, perhaps you can answer the next question as to the first part is, how do you manage neglected neurogenic clubfoot following injection of the sciatic nerve 5 years ago in a 7-year-old patient? And then generally, how do you manage the neglected clubfoot?
I didn't see the second part of that. Okay. I'm not sure if neurogenic drop foot always leads to a clubfoot. I mean, I've seen a lot of drop foots after sciatic nerve injuries, only few cases of club feet, but again, it follows the same protocol as the normal treatment of a club foot. You have to do your scoring. If your scoring gives you an indication that you can be successful with conservative treatment, then you go for the conservative treatment. Now, I don't see the second part of the question, if you remind me.
The second part was, how do you manage elder patient, those who are not managed in an early age? So essentially, how do you manage neglected clubfoot?
Well, as we said here, up to 10 years, you can still try the conservative treatment. Some do it actually longer. I saw in that study from Nigeria that I looked up, they had patients in their study up to 16 years of age. On the other hand, I personally have seen patients, especially here through APDK, like 18-year-old, 19-year-olds. And to be honest, I was too coward to attempt a massive surgical procedure, and I gave them a clubfoot shoe.
All right, then I'll skip to Lusweti Mudhumbi. Who should be the first to be consulted in case of a newborn with clubfoot? Is it the orthopedic surgeon, the orthopedic technician, or the occupational therapist?
Ideally, the midwife should recognize that a child has a clubfoot. And if you are in a hospital where you have an occupational therapist, I think the referral can go straight to the occupational therapist. In most hospitals, you won't have, at least I've only worked in government hospitals in Kenya, so I'm not used to private setting. An orthopedic surgeon can be consulted, of course. Orthopedic technician only comes in later when it comes to bracing. So as the situation is in Kenya, where the OTs treat the club feet, I think the midwife should refer to the OT.
All right. From Steve Bakker, do you recommend a series of casting before any surgery in a neglected clubfoot in the older child? I think you've answered this one. Over 10 years, or can you go straight to surgery if the severity score is high?
Yeah. Even in very severe ones, you won't lose anything if you attempt a few casts. So I would always cast first, except now if I have the Paver and I have a Paver score of 20 or above, then the chances of getting anything done with the cast is minimal. On the other hand, you don't lose anything if you try a few manipulations and castings before you go for surgery.
Okay, the next question is if there is need for repair of the Achilles tendon after tenotomy, and if none, then how is the plantar flexion restored?
The Achilles tendon is something very interesting, especially in children. I mean, in the original Ponseti treatment in the young children, you do a complete tenotomy anyway. You don't do a lengthening. You just snap it, and it grows back. There is an anecdotal story of that happened during the Spanish War, and I think Ponseti was involved in that story too. They had prisoners of war, and to prevent them from running away, they cut their Achilles tendons. So those guys were adults, and some of them started running away 3 to 4 weeks later and could walk again. So they cut their Achilles tendons every month, basically. It's not that obvious, of course, in children. If you have an older child and you attempt a percutaneous tendon lengthening, it will happen that you rupture the Achilles tendon completely. But you still have the peritendinoeum, the tendon sheet, which is there. And I'm convinced that in 98% of the cases, the tendon will grow back and you won't have to do a surgery.
All right, or maybe a combination of Dickens and an anonymous person on the issue of tenotomy. Must all the patients going through Ponseti treatment have a tenotomy? Yes. That's one. And secondly, how do you make the decision on who is to get the tenotomy?
Well, the decision is easy. They all should have tenotomy because, in my opinion, if you don't do the tenotomy, you will produce a rocker bottom foot or some other form of deformity. So the Ponseti treatment is defined actually as manipulation, casting, tenotomy, and bracing. The tenotomy is an integral part of it.
All right, and for the last question, after correction of the neglected clubfoot, are patients able to run and or cycle?
If everything goes well, they will, but as you have seen on some of the pictures, the patients with severe clubfoot have quite severe muscle atrophy, especially of the calf, and it will take them a long time to develop those muscles again, but I don't see an issue. I've seen only one patient, which I saw 5 years after treatment, who had a very severe clubfoot, and he was actually running. He was not only able to walk properly and cycle, he was actually running.
All right. Thank you very much, Dr. Kinsch, for the time to even make the presentation.